important webinar, and it is a platform in which we hope that there would be a lot of public participation and discourse on a topic that's crucially important for the 105 plus million tribals in India, spread right across the country, and also for any efforts being made to strengthen the health system in the country and to enable access to good quality, inclusive, universal health care. The Lancet Citizens Commission is a very ambitious cross-sectoral endeavor, which is trying to, in a way, add to the momentum of the efforts that are already underway to improve access to healthcare as one of the core determinants of improvements in health. We know that there are multiple determinants of health affecting all citizens, but tribals in particular have greater vulnerabilities, along with the huge strengths that they also carry with them through generations. The word health security is often associated with international understanding of preparedness for pandemics or for outbreaks, etc. We have consciously used it here to broaden the scope of that, to understand that there are various other risks faced by tribal communities by virtue of their the geographic terrain and by virtue of the multiple risks that they face in their life. And therefore, it's important to have an expanded understanding of the term health security. The other factor to keep in mind is that there's this ongoing debate between whether we should use universal health coverage, universal health care. I think most of us feel that we are committed to this concept of health for all, which was first articulated in the Alma Ata Declaration and to which many of us subscribe. And that has been an endeavor that has generated and inspired people across the globe to redouble their efforts to improve health conditions and health outcomes for people, given that there is sufficient knowledge, medical knowledge, public health knowledge, and all types of social knowledge, as well as sufficient resources. Human resources may be still more limited, but there are sufficient financial resources globally to achieve these goals. So the Commission is using a multi-pronged effort, including research, including evidence synthesis, including across 5 work streams. And the monthly public webinars are one such effort to create this public dialogue. There are also newsletters, there's a website and a variety of ways by which young researchers, anybody who's interested can get involved. So please feel free to join this process. So today's webinar is co-hosted by SOCHARA and the Population Foundation of India, PFI. So SOCHARA is based in Bangalore and PFI is Delhi-based. We know that there has been an important national report, the Expert Committee Report on Tribal Health in India, and we have the chairperson, Dr. Abhay with us today. We have an extremely wonderful panel lined up for you, when I reflect on their work, I think they make the impossible possible. That was the idea that came to me as I've been looking at the work and the life achievements of the panelists here today. So it's a great pleasure for me to actually introduce to you Dr. Christo Kharkongor. He is currently the Chancellor of the Martin Luther Christian University, which is based in Shillong. It is a tribal university and the majority of the faculty as well as the students are tribal from the Northeast region, but also include students and others from different parts of the country. Professor Glenn is also Professor of Health Sciences. After his studies in medicine at Christian Medical College, Vellore, he did his residency in pediatrics and a master's in public health in California and the US. He then came back to India and worked for decades with the Manipal group, becoming their professor of pediatrics and closely involved with the management in a range of different initiatives that actually had a social justice approach to make affordable healthcare possible. He then, I think, started a major part of his life work, which is going back to Shillong and setting up, along with many colleagues, the Martin Luther Christian University in 2006, if I'm not mistaken. And this university now reaches out to several thousands of students from the Northeastern region. And there is a build-up very systematically of the traditional knowledge systems in the region through the research work being undertaken by students and faculty of the university. Dr. Glenn has authored umpteen professional papers, but I must bring to your notice that he's a very prolific writer and writes extremely well and has written a number of books. I could spend the whole 1 hour discussing the three panelists, but I will move on and introduce Dr. Melari, who's presently the Associate Professor at Indian Institute of Public Health in Shillong, and has done enormous work from her days working after she finished her studies in Tata Institute of Social Sciences, to working with flood-affected people, to being a director of an NGO, and completing her PhD, supporting tribal projects with communities on traditional knowledge systems in the Northeast. And now she's taken this entire body of knowledge with her to the IIPH Shillong, which will benefit the entire public health community. Dr. Abhay Bang is very well known in the country for his work based in Gadchiroli in Maharashtra. He grew up in the Sevagram Ashram in Wardha with Mahatma Gandhi's presence, and he has been a gold medalist in internal medicine from Government Medical College, Nagpur, did his master's in public health in Johns Hopkins, was actually a distinguished alumnus award. It was bestowed to him in 2012. And he has, together with his wife, Dr. Rani Bang, and a whole team, set up a search in Gadchiroli, which works with the Adivasi communities in 124 villages. But their work, especially their research work, scientific work, and their community-based work, including campaigns, has had ripple effects across the country, especially home-based neonatal care and the care of pneumonia, with community-based care with community health workers. So without further ado, I would request Dr. Glenn to give us an overview picture of the tribal health situation based on your experience, and set the tone for the webinar. Thank you, Dr. Glenn.
Thank you very much for those introductions, Thelma. I'm really privileged to be on this panel, and my thanks go to the Lancet Citizens Commission and the South Asia Institute at Harvard for this opportunity. I'm especially pleased to be in the same room with people like Dr. Thelma Narayan, Dr. Abhay Bang, and Dr. Melari Nongrum. I belong to the Khasi tribe of Meghalaya state in Northeast India. Out of the 3 million population of our state, about 85% are tribal. We consider our university to be a tribal university because the approach, the philosophy, the clientele, the staffing are all from the local tribal people and from the regional hill states. We are very focused on local problems, and we are grounded in our tribal culture. In this discussion, perhaps we will use the terms indigenous people and tribal synonymously. The most common word for tribals in India is Adivasi, which means original inhabitant. And the ancestors of India's tribes came out of Africa about 70 to 100,000 years ago, according to the National Geographic Project of the National Geographic. I'll begin, Thelma, by looking at some broad stroke issues. These remarks will be of a general nature to try and provide some context to the discussion that we are embarking on today. In India, there are about 105 million tribals, which represents 8.5% of the population. If we had our own country, we would be the 13th largest country in the world, about the size of the Philippines or Russia. Okay? Larger than any country in Europe, apart from Russia, of course. And if you take the 350 million indigenous people around the globe, okay, the indigenous people would be the third largest country in the world after China and India. So we are not talking about pocket communities or small groups that have some particular cultural or socio-economic characteristics. We're talking about a large chunk of India's population. Considering that the tribal population is this large, it stands to reason to make the question, okay, have we been given enough attention in terms of tribal health? There has been an expert committee that brought out a very copious report called the Tribal Health Report of India. In this committee of 12 members, okay, only 2 are tribals. This raises the question as to why is it not that tribals were in a majority in such a committee? Because if everything was going well with tribal health in India and we had excellent indices, then these questions would not be pertinent. But the fact remains that 7 decades after independence, 70 years ago, I will quote a question that is posed in the preface of this report on tribal health. And reading verbatim, this quotation says, nearly 7 decades after independence, why do the tribal people still suffer from the inequity in health and healthcare compared to others? Tribal IMR, the infant mortality rate, has halved over the last 25 years, okay, but the gap with other social groups has widened. There are some other admissions that are made in this report. Healthcare for tribal people remains subsumed in rural healthcare. It is assumed that tribal people have the same health problems, similar needs as other rural populations. However, we do know that there are different cultures and hence different healthcare needs were not addressed. Okay? How would the nation know? No separate data on tribal health were maintained. So the Tribal Health Report in India makes these very important and these very relevant observations. So if you look at what is the baseline from which the report begins its deliberations, it is tribal health is dismally poor. In fact, the gap between tribals and non-tribals in India, the indices have widened. Separate data sets are not collected, and tribal culture is not on the health radar. So full points to the commission, to the expert committee, for bringing to the surface these important points. Given that there is a large population of tribals in India, and that many separate and distinct characteristics of tribal health has been pointed out in this expert committee report, okay? Yet it is probably a deficiency that tribal health is not taught as a separate subject in medical schools or in nursing schools, or even in schools of public health. The Tribal Health Report, while pointing out the neglected approach to tribal health care, says very little thereafter in the 300-page note. So having agreed that there are certain basic issues in the approach and in the context of tribal healthcare, somehow the rest of the report goes back to malaria and malnutrition and malignancy. And these important contextual issues have really not been given sufficient consideration and sufficient space. We actually had a question that came to this panel even before the webinar started. And this question is something that I'd like to touch upon. And when I look at the name of the person who sent this in, I realize that it's not a tribal. But this person says that I would like to take upfront the issue of security and surveillance, meaning that the tribal people are not granted sufficient agency and autonomy to answer questions about their own security or safety, or ways in which that their health status is surveilled. So This paternalistic attitude to tribal health is something that has survived colonialism. It has remained so during the 7 decades after independence. And tribals, because they are considered to have so many deprivation characteristics, are also described in these terms. And who describes these terms? These are NGOs, these are institutionalized public health organizations, these are funders, these are health policy makers. In other words, okay, this paternalistic mindset in relation to tribal peoples, okay, seems to be the attitude by which tribal health is approached. So when we talk about tribal health, it's more than just an issue of social justice or equity. It actually comes down to agency and autonomy. That's the first issue. The second issue that I'd like to take up is, our problems with aggregated data. Generally, any discussion on health begins with looking at data. If one is considering tribal or indigenous health, there is plenty of compiled data on the WHO website. We have special issues on indigenous health brought out by Lancet in 2009 and 2016. We have national data such as what is found in the National Family Health Survey or the National Sample Survey. So there's plenty of this aggregated data. Okay? And of course, aggregated data has its own function. It needs aggregated data to inform public policy or to inform special health schemes. But this is where the usefulness generally ends. Okay? Aggregated data is a big homogenizer. And the 100 million tribals in India belong to more than 650 official groups. And these 650 tribes can be vastly different from each other in culture, social structure, and economic capacity. Generally, the feeling is that all tribals suffer from poor health indices, but even that is not true. In the northeast region of India, there is a tribe in Mizoram, okay, which has very high health indices. But in our own tribe in Meghalaya, just a couple of 100 kilometers down the road, we have some of the poorest health indices in the country. So this aggregation of data does not have much use for us when we are looking at a local problem. Maybe we don't need this much aggregated data. The only disaggregation that happens from NFHS is district level data, but even the district level data does not separate tribals and non-tribals. So apart from these issues with aggregated data, other questions arise. Many of the data collectors are from other parts of India. They are reading the questions to the households from an English questionnaire. Sometimes they use an interpreter, so we don't know in the interpretation whether anything is lost. Okay. Tribal communities are small communities, and we have noticed that there is also survey fatigue because governments are doing surveys all the time, NGOs are doing surveys, academicians are doing surveys. Okay. Our best researchers tell us that generally tribal communities are forthcoming with truthful data, okay, only if they have good rapport and trust with the data collector. So if someone is going in and out of a community, it's unlikely that accurate data is being collected. Thelma, where are we in regards to time? Do you have a few more minutes?
You have about 5 minutes.
All right. So I'll take up the third issue, and that is cultural unfamiliarity. The Tribal Health Report says a lack of understanding of tribal culture and an imposition of schemes and mechanisms that are culturally alien to the tribal people have exacerbated the problem. There is much truth in this statement. However, when the report concludes, okay, with the 10 challenges around which the deliberations and discussions have happened, cultural understanding is not mentioned. So ultimately, data collection and working with tribal communities boils down to cultural familiarity and comfort. Okay? Without this, data gathering is really hampered. When we wish to collect data, with a view to conducting a particular intervention or a project in a community, generally we will go to the community and ask them, okay, what are the issues here? Because the health questions are not a secret. You go to a village and everyone knows what the social problems or what the health problems are in that community. So I don't need sophisticated data to tell me what's going on there. So the information that we need is not in tables, graphs, or p-values. We don't live there. So this aggregated data, which may be several years old or which may have come from a homogenized tribal approach to data, may be for a particular community some kind of a misfit. We haven't talked about mental health. We all know that culture permeates mental health. If you look at DSM-5, the Diagnostic Statistical Manual, it is only in the 5th edition that cultural distress is mentioned. ICD-10 has an annexure now in its latest edition about cultural syndromes. So unless we are familiar with the cultural underlay of disease and how the folklore and how the traditions and how the belief systems impinge on that health problem, we really cannot get at the root of it. Let me tell you a little story. A few years ago, one of the students in our university, a teenage girl, became sick. So she lost her appetite, she had low energy level, she was anxious, she was depressed. And she was taken to the hospital, and there she was given good medical care, and she was treated by the psychiatrist. And I saw words like anxiety disorder, conversion disorder in the chart, and they gave her some medicines and they sent her home. But she wasn't well. So the family decided to call the local healer. The traditional healer said someone has cast a spell on her. In our community, that's called Taro, T-A-R-O. And the healer said that unless the spell is recalled, okay, she will not get well. So he happened to know the family that had cast the spell. So he went back to that family. The two families got together. There was a reconciliation. The family that had cast the spell said that your daughter came to our house, but she didn't behave very well. She wasn't grateful for the food that she ate over here. But what happened in the end was that with the reconciliation, the Taro spell was withdrawn and the girl became completely back to normal and came back to the university to continue her studies. Some questions arise over here. Are we prepared to teach cultural syndromes in our university? Are we prepared to tell our counselors that they must also keep in mind these possible cultural syndromes when they see a person with distress? If we are unable to adequately treat a tribal with such an illness, are we prepared to refer that person back to the traditional healer? Are we prepared to bring the system of indigenous medicine into our health system in an attempt to have pluralism? So this is an example of how culture is so important, not only in physical health, but also in mental health. So these are just a few broad stroke issues, Thelma, that I wanted to place on the table, and I'll leave it at this for now.
Thank you very much, Glenn. And I'm sure we'll get back to you with further questions, including from the participants. I would now request Dr. Melari Nongrum to actually take us on a little deep dive into the health situation in Meghalaya and any thoughts that you may have with regard to steps to be taken in the future. Over to you, Melari.
Yes. Thank you, Dr. Thelma, for this opportunity to share my experiences on working in the field, in especially Meghalaya. And I'm very grateful that we have this webinar to discuss on issues related to the tribals. And like Dr. Glenn, I'm also a Khasi. And in Meghalaya, as we all know, the Khasi and the Garo tribes are predominant. And it is also, hilly in terrain with high precipitation. In fact, we have had, the longest, rainfall, in the past almost 2 months, we've had perpetual rainfall. We have extensive forests and rich biodiversity. And this has influenced our food and healing systems in our community. And our community also still practices traditional knowledge systems related to food, healing, music, arts and crafts, among others. I'm trying to change the slide, but yeah, okay, I'll just do this, yes. In terms of policies, I would like to state that our state has passed its first state health policy in the year 2021, very recently, and it has an enabling component, which I could say it's quite progressive, where it looks at the women's empowerment as being an important component for improving health outcomes among the community. The other program that I would like to highlight is the Integrated Child Development Services, which is an old government program which has been implemented since 1975. However, as one of its services, the Supplementary Nutrition Program, we always see when we go to the communities that the food that is provided is somewhat, many a times, not culturally relevant. This is because the procurement of the food for the ICDS is centralized. So therefore, many children do not like the food for many items, and therefore the food is not eaten and in fact given to the pigs, which is very unfortunate. The other program that I would like to highlight is the midday meal. One of its objectives says to increase enrollment and also the nutritional status of our children. Now, as you can see, the allocations are very small. And therefore, when we speak to teachers about what is the quality of midday meals in their schools, they say that it is really difficult to give them nutritious meals to children, because often it is not just, this 3 rupees is for this particular child, but actually sometimes this small allocation has to be spread to even other children. For example, the children who are at 4 years or 5 years who are in the same school. So such practical challenges are there when we implement such programs. I would like to also bring the context where, in terms of the multi-dimensional poverty index of the Niti Aayog, we see that Meghalaya is the 5th poorest state in the country, with almost 1/3 of its population, which is multi-dimensionally poor. And we know that this poverty index has taken into account the health, standard of living, and education. In terms of the health indicators for children and women, as you can see, we have children who are stunted, almost half of them. We also see children who are underweight, which is 26%, and also, very importantly, children under 5 years who are anemic, almost half of them, and also women, which points to the fact that this is almost a cycle where a woman bears a child and that child continues to be anemic. So these are the realities that we see also among children and women. We also see that the mothers who've had 4 antenatal checkups is just about half, and also children born at home is still, more than half of them are born at home. Now, what's the problem of children being born at home? It's okay if it's a normal delivery, but however, if there are complications and in the hilly terrains like Meghalaya, then it becomes difficult to access healthcare, for emergency services. Some of the determinants from my experience that we've worked in Meghalaya is the dietary diversity. We had done recently in 2019 a study that across Meghalaya to look at dietary diversity. And we had taken the FAO model for this of the 10 food groups. And the dietary diversity score was 4.22 out of 10, which is less than the minimum requirement of 5 food groups per day. And and it is surprising to see this because we are living in a context where there's high biodiversity, where communities and people can access wild vegetables, fruits, nuts and seeds, and also eggs, because many of them, especially in the rural areas, would rear chicken. So therefore, I will talk about later and highlight why is there poor dietary diversity, especially the consumption of traditional food. In terms of micronutrient deficiencies, I would like to highlight one study that we had done on clinical vitamin A deficiency. And in fact, this was part of my PhD, where we found that among preschool children, there was a prevalence of 2.49, and among 5 to 15 years, there was 5.9%. And interestingly also, we found that there was a Khasi local term called matyar, which refers to the night blindness. So we can understand that this condition is actually very common for a community to have coined a term for such a condition. And also we found that in the communities, people actually always ask the person who has a night blindness to also, take beef liver in the raw, boiled, or the roasted forms. Another phenomenon that is actually affecting adolescents' health is teenage pregnancy. And recently, actually last year, the Meghalaya State Commission for Women had brought out this report where they've highlighted issues of adolescence, and one of which is teenage pregnancy. And this has led to the health issues of adolescents. There's a lack of contraceptive services and also dropping out of school, which is a very big concern in the communities. We also have high substance abuse, especially alcoholism. And I would like to point out that children bear the brunt of alcoholism of the parents. 67%, as we can see, have witnessed quarrels and fights, and this has affected the mental health of our children, and also other ramifications in terms of economics and the social ramifications on the children. Drug abuse is another increasing problem in our community. According to this study, a national survey, they have stated that there are about 11,420, and children as young as 13 and 14 years are introduced to drugs. And in fact, I'm also involved in another ongoing study among drug users, and they say that the access and availability of drugs is very, very easy in today's context. And therefore, that could be one of the reasons of drug abuse among our adolescents and young people. Another important component that I would like to highlight is the tobacco consumption. The northeastern region as a whole, almost all the states, have a high tobacco consumption, and Meghalaya is second highest in smoking, and also quite a high percentage of in the smokeless tobacco. And this is actually creating concerns in the cancer burden, and we'll look at it in just a moment. But however, I'd like to also bring out a traditional practice in our community, which we say we consume kwai. So kwai is actually a combination of the areca nut, the betel leaf, and the lime, which you can see in the basket, and this is called a shang kwai, and is always available, in every Khasi household. And this is actually, a social, when we meet with other people, we always, the first thing that we give kwai. And this is actually not taken to be tobacco, but many a times kwai is being eaten with smokeless tobacco, like especially the tobacco leaf. So therefore, it does causes a lot of problems, I believe. And therefore, when we look at the cancer burden, the entire northeastern region is considered to be a hotspot for cancer, which is very sad. Meghalaya ranked as second in the prevalence of cancer, and the leading cancer in Meghalaya is esophageal cancer, which I believe is a result of probably the high consumption of tobacco and also the kwai. And as we can see, with when we were before starting this webinar, we were talking about the weather. For the last from April onwards, we've had incessant rainfall, and these are very recent pictures of what the state has been experiencing, and many places have been cut off, from accessing those places. So, however, in this whole context of accessibility and all the problems that we have, I believe that if we were to talk about universal health coverage, to achieve that, from our context here, we need to focus on the traditional knowledge systems, especially on food and the healing systems, which are very prevalent in our communities. We need to promote the good traditional practices. We do not romanticize the traditional knowledge practices, but we take the good practices. For example, in the traditional medicine, and have done some work in the past on traditional medicine, we find that almost in every small cluster of villages, there is a traditional healer up till today, both in the urban as well as in the rural areas. People access the traditional healer, and therefore they are accessible and affordable for primary health care. So therefore, instead, we have done a survey and we asked about the system of Ayush. People, especially in the rural areas, and in fact, even in urban, many people did not know about Ayush. Probably they had some ideas about homeopathy. So therefore, instead of bringing in systems from outside, like a system of Ayush, why don't we promote the traditional medicine system of our communities, do more research and promote the good components of our traditional medicine systems? The other is the food system. Now, there needs to be a mindset change regarding traditional food systems. And that I say it's even among our own people. The fact is that traditional food is being looked at as poor man's food. It's been looked at as food, that is not so nutritious. So, however, in the work that I've done on traditional food, we have found that the traditional food is actually nutritious, better, or even as nutritious as market foods. Now, why is this mindset? I believe that it is in our education system. We have our school books, we read herbs, we read about fruits right from the time we are in, the primary level. And every time we read about a fruit or a herb, it is nothing that we find in our, in our system, like our local fruits. It's always an apple, it's always a mango that we've, it doesn't grow in our area. So children and every one of us grow up to understand that probably it's an apple that actually, more nutritious than anything else, than any of the other traditional foods that are available seasonally in our communities. So therefore, there has to be a mindset change at all levels, right from the children and therefore adults and also policymakers, so that they can look at how to include traditional food in our supplementary nutrition programs. That is very important because, as I said, the central procurement does not always result in very good, in very good consumption of that food. So why not include traditional food? And many of the traditional food that we find has been, assessed, of its nutritious value by, by many researchers. So therefore, even in the Indian food composition tables, much of our traditional food is there. So why not include these foods in the SMP? The second point that I would like to bring is on education. We need to, although we have a relatively high literacy rate of about 74%, but we have high dropout rates. There is no discrimination among girls and boys in terms of education in our communities, but then there is a school dropout at primary level, middle school, and secondary school. And we all know that education improves health outcomes. So we need to figure a way to reduce the school dropouts, and there needs to be, a convergence, I believe, between the health and the education sectors. The second is a bottom-up approach in the behavior change communication. Much of it has come, from top down, and it has, to whether it's a print media or electronic media. However, I believe that if we were to really change behaviors, for example, even tobacco for that matter, it has to come from a top-down approach. People have to see that it is a problem, and then they have to strategize. In fact, I'm in the middle of a project where we are going to get this project, where we are looking at how do we change, how do we involve women, at the grassroots to actually look at tobacco-related behaviors and also self-breast examination. And how can we change behaviors? I believe that is very important to achieve optimal health outcomes. The other and the last point is the importance to link between social and environmental factors affecting health. Just a last example. If our environment is degrading, many of our communities will be more and more dependent on the market. And if they are dependent on the market, they will have poor dietary diversity. Even now, they have poor dietary diversity, they'll have more. When I was doing my PhD, it was an area where they had large-scale broom cultivation, which has replaced, a large forest. So therefore, what happens is that those families were dependent on the market, and during the lean season, their diets were very poor. So therefore, when we look at health, I believe we need to link the social and environmental factors affecting health. Thank you so much.
Thank you so much, Melari, for giving us a deep insight into, the core issues that are faced by tribal communities in Meghalaya, Khasi, Garo, and maybe Jaintia as well. And also your thoughts about the way forward. We will now move to our third panelist, Dr. Abhay Bang. And I would request Abhay to please give us a little bit of your experience with the National Expert Group. And maybe in the second section, also a little bit about your work in Gadchiroli through search. Over to you, Abhay. Yeah.
Thank you, Thelma. And also thanks to the Lancet Citizens Commission for taking up relatively unorthodox issue of tribal health in a global health discussion. So it's a very rare opportunity that the issues of tribal and tribal health in India are being discussed in such an important forum. Eminent co-panelists with me, and so they have covered a lot of ground. And, as Thelma suggested, we take a very health in India as seen and as reported in the tribal health report by the expert committee on tribal health, which I had chaired. This committee nearly 5 years, and the report you can see there. Now, very quickly, according to 2011 census, we have 104 million tribal people, 8.6% of India's population. And as Dr. Glenn very eloquently compared with various countries' population, so actually tribal population in India deserves on numerical basis to be considered like as important as an independent country. And there are but 5 tribes within that. So tribals and India is not a homogeneous one entity. They live in different parts of India, mostly in 10 states in the mainland part of India and in the north states. Important characteristic probably throughout in every that they are geographically usually marginalized. They live mostly on the periphery of the state, except
Dr. Abhay, your voice is, we can't hear you for a minute. Yeah.
They are marginalized,
Yeah.
both geographically, socio-economically, and politically. Here, we can see that out of states, the tribal population, majority of tribal population lives in these 2 triangles. Within this, there are 90 districts which are tribal majority districts. There are other 60 districts where 25% or more population is tribal. And tribal people are concentrated in 809 blocks. So when we usually talk about tribal people, tribal health, etc., we have in our mind those 809 blocks, which are tribal majority blocks. But interestingly, half of the population, tribal population of India lives outside these tribal areas. And they have their own problem because they are scattered minority in wherever they live. So why was this committee constituted by the government of India? Health Ministry as well as the Tribal Ministry together jointly constituted this committee in 2013 to answer these two questions. To make the diagnosis of status of health and healthcare in tribal areas and to make recommendations about how should the roadmap should be and to bridge the gap between tribal and non-tribal people's health. Now, I'll not go through the details about the methodology, but we were blessed with 12 very eminent expert members drawn from different parts of India. And we got full cooperation from the Health Ministry and Ministry of Tribal Affairs. But our findings were there is dismal lack of data on health of the ST population, tribal population in India. And as Dr. Glenn correctly mentioned, often it is aggregated data. We do not get disaggregated data on tribal people's health. National NFHS survey, the sample registration system, the national sample surveys, none of them try to give you separate estimates about tribal health as if they do not want to share this with you. Now, the 5 major broad findings about tribal health that we found. Health status of tribal people has certainly improved over the decades, and I'll come with little data on that. And yet, on most of the indicators, it is worst as compared to the other sections in the society. Now, this is figure drawn from Lancet Commission, Lancet Lovitja Commission, of which I was a member, on international situation of indigenous people world over. And as you can see, the infant mortality rate, India has the dishonor of having the highest infant mortality rate in indigenous population, only next to the Pakistan, which is not a very graceful thing. And so, IMR of indigenous people or tribal people in India is definitely worse as compared to tribal people elsewhere in the world, except in Pakistan, but there has been improvement. If you look at the infant mortality rate in NFHS 1, 2, 3, 4 for the tribal population, on our request, IIPS gave us a separate analysis of tribal sample within their NFHS survey. So one finds that from 90, the IMR of 90, over a period of nearly 25 years, it has come down to 44. But it is still higher than the Indian average and definitely higher than in the rest of the non-tribal population. Let me take one example. This is NFHS 1 to 4 data, and this is under 5 mortality. Now you can see that from in the ST population, from NFHS 135, it has come down to 57 in tribal population. Great, good achievement, but juxtapose the under 5 mortality in the non-tribal population. And you can see that currently the most recent data available to committee was NFHS 4, but it was 50% higher in tribal population as compared to the rest of the population in India. And on this side, now you can see in this last column, what is the excess under 5 mortality in STs? So it was 21% excess in NFHS 1, 1990-92. Now it has become 48% excess. So child mortality has definitely decreased, improved in tribal population, but the disparity with the non-tribal population has increased. Tribal people suffer from a triple burden of disease: child mortality, malnutrition, mental health problem. Second is communicable disease. And third is mental health and addiction issues. So they face triple burden of disease and a large burden of common illnesses. The National Institute of Tribal Health Research in Jabalpur has done certain surveys, and they find that a sizable proportion of population in tribal community at any given time is suffering from one or more of these diseases. So it means that there is a need for accessible source of basic health care in the community itself. You cannot have health center 15, 20, 30 kilometers away when half of the population in tribal community having one or other sicknesses. We also saw evidence of early epidemiologic transition with increasing hypertension, diabetes, cancer, and the quantum of persons with healthcare needs at primary healthcare level is very large in tribal communities. Now, what is the healthcare infrastructure situation? Just to take one indicator, out of the 18 states, what was the shortfall of health personnel in government institutions? And you can see the numbers. Actually, subcenter shortfall is underestimated because now the number of personnel expected at the subcenter is much higher. So there is a huge shortfall, and this is only shortfall on the paper. In reality, the shortfall definitely would be worse. This is one photograph I took from the constituency of the ex-chief minister of Nagaland. And his own village, the primary health center for the 6 month was closed. So this is how, and that's why, because the government health services and system is inadequate on quantity, on quality, on human resource, people often have to resort to herbal medicines. It doesn't mean it is necessarily bad, but then there is no validation. And even in herbal medicine, a lot of commercial element has crept in. And the actually use of the rich tradition of traditional health care and health in medicine has not been appropriately made at all by the national healthcare system. So our diagnosis was that health and healthcare gap between tribal people and others is 30% to 1100%. 1100% is malaria and tuberculosis gap. The healthcare system is very weak in political representation and participation of tribal people in deciding priorities, planning and governance, in administrative mechanism, in planning and financial accountability, in healthcare delivery, and finally in data. So the committee felt that there is a need for restructuring and strengthening is needed in accordance with the need and culture of the tribal people. And this restructuring has to be done with the full participation of the local scheduled tribe people. So the planning and designing has to change from geography to geography, maybe sometimes community to community. So our recommendations were based on these principles. As you can see, I hope these will be universally acceptable principles, but they are not paternalistic. The principles on which the recommendations are based on universal human rights, justice, fairness, autonomy, decentralized planning and administration, acceptability by the local people and cultural sensitivity, universality, and finally, empowerment of the tribal people should be the centerpin. So our recommendation, universal healthcare in India must begin first in tribal areas because Antyodaya, they have the worst health status, worst health care. So any attempt of universal healthcare must first begin with the tribal people. And the goal of tribal health care should be at least that within next 10 years, the health status of the tribal population in India should come at par with the average in the respective states. We began with how governance needs to be changed and how participation of tribal people has to be increased, but through various mechanisms. We felt that the tribal health currently is subsumed and neglected in the NRHM and universal healthcare, and it is endangered. And so 3 types of dedicated governance structure at the national and state levels have to be created. in each state and at nationally, a tribal health council having large representation of the tribal representatives and people who are tribals themselves. Tribal Health Directorate for the administration of tribal healthcare and Tribal Health Research Cell within the Department of Health Research. Participatory forum for planning and discussion at the local level have to be created, and district tribal health action plans, district specific tribal health action plans have to be generated in at least 151 districts where there is a sizable tribal population. There are several suggestions about organization of service delivery. I will not go through all of them, but the main principle is move healthcare delivery towards the communities. Wherever tribal communities live, healthcare must move towards them. Engage and empower local ST people, local tribal people for their own health and healthcare. And healthcare basket should be broadened, should not be limited to few diseases. One recommendation is knowledge is the best vaccine and the best pill. So massive health literacy drive amongst the tribal people, so that a large gap of maybe 1 or 2 centuries knowledge gap that they suffer should be at least partly bridged. Primary health in each community. So there has to be health literacy. Arogya Mitra is another concept. In addition to ASHA and community health worker, we felt that there is a need for local participation. Arogya Mitra, traditional healers, and each village and hamlet should have at least one ASHA, one for 50 households, and the village council and tribal health assembly should be constituted. Human resource for this, how should it come? How should it be selected? Its characteristics. But in having human resource for tribal healthcare, we felt that the local is central. Delhi is not central, but local is central as far as the tribal health is concerned. There are special health problems in tribal areas. You can see a list. I won't go through the details of these, but the report discusses these various problems and possible solutions. There is an issue of nearly half the tribal people, ST population as per the census. They live outside the scheduled areas, these 809 blocks. And they are minority. They are in urban slums. They are in rural areas where they are either bonded labor, or earlier they were bonded labor, but they are agricultural labor. They are landless. They are scattered minority and disempowered families scattered throughout India. They need health facilitation mechanism. At least people living in scheduled areas have some advantage of being majority, being community together. These people are helpless, marginalized. So we have made several recommendations for these nearly 6 crore tribal people living outside tribal areas. They are the displaced people. Financing tribal health is a major issue because there is a big scandal, hidden scandal here. The national guidelines and the planning commission guidelines mention that a certain percentage of health budget as well as all development programs budget, percentage equivalent to the percentage of tribal population has to go for the tribal sub-plan. And committee recommended that tribal health should receive at least equivalent to 2.5% of GDP per capita, which is the goal of the national universal health coverage recommendation also. And so at least this must begin with the tribal people, that we allocate that much money. Currently, we allocate nearly 1 to 1.5% of GDP. So it must be increased. And if we follow the TSP guidelines, which I mentioned, which are not only flouted, but the government doesn't keep even data. How much money is allocated for tribal health and how much is spent. So we recommended, based on 2014's available data, 2014 data, per ST capita, 2,500. Now, if you go by GDP calculation, this will be about 3,500 per ST in the country. There should be transparent accounts, financial monitoring, and segregated data on tribal health money being spent, and financial accountability locally to tribal Gram Sabhas and nationally. The report was presented after 5 years' work to the full range including then Health Minister, Mr. Nadda, and Tribal Minister, and secretaries, and ICMR, and health secretaries, everything. The Health Ministry said, we will act on the report. Niti Aayog said, we will act on the report. Everybody said that they will quickly act on the report. But to my knowledge, and even Professor Amartya Sen blessed this report, which is equally important for us. But then, sufficient action has not happened so far. Government, Ministry of Tribal Affairs has done something, some brainstorming, some ideas, some initiatives. Health Ministry has done something. But there is no National Tribal Health Mission, which the report recommended. There are no tribal health councils. There are no tribal health directorate. Money has not been allocated. And most of the recommendations have not been acted upon. Now, what can civil society or those people who are attending this webinar, what can we do for tribal health? Now, tribal people are marginalized politically also. They don't have voice. So somebody else has to probably, along with them, taking them together, but somebody also has to work with them. And so disseminate and discuss this report, its finding, its recommendations. This report is not the last word, but it's the first tool which becomes available in organized data and recommendation form that tribal health has to be looked at more seriously and given fair trial in this country. Secondly, there is a need to generate this demand and pressure. Unfortunately, tribal society as it is divided in 705 tribes. So there is not enough political awareness as well as political pressure from tribal people in India to demand for tribal health. Third thing that we can do, that we can do various micro studies and micro pilots on tribal health, which probably would generate evidence that tribal health, how tribal health delivery could be done in a participatory way with the local tribal people. So this is briefly to give you idea. I must thank all these people without whom this report just wouldn't have been possible. And report is available on the website, in ministry's website and the search website. And there's a special another website also. So it should be accessible. Now, very quickly going to what Thelma suggested that I should briefly talk about Gadchiroli also. For the last 35 years, my wife Rani, I and our colleagues, nearly 100 colleagues, all of us have been working in Gadchiroli, which is at the eastern end of Maharashtra bordering with Bastar. Our organization is called Search, and few experiences and attempts I'll share.
Abhay, I'm just wondering, sorry for interruption. Can I take one or two questions and then we come to Gadchiroli?
Sure, most welcome.
Just so that, participants also, are heard. I would just like to, there was one question about, the tribal, the situation of malnutrition that is faced among tribals and anemia. And there is an assumption among some that, the availability of local millets and local forest produce. So what is the reason, and is it uniform across all tribal groups? So I would suggest, and also what can be done. So Abhay, I'd like you to reflect on this question regarding the nutritional status as you talk about Gadchiroli. So please continue here.
Thelma, I'm going to disappoint you on that, but I think Melari talked about the importance of millets and local available nutritional food dietary patterns, and I completely agree with her. And hopefully Government of India is realizing that now the importance of millets also, but we are far from it. And as the national NNMB data survey of tribal health in India, they report nearly 60% prevalence of anemia in tribal population. So it's a serious issue, needs much more attention. But what I'm going to share here is how can a participatory model of tribal health be attempted in fragments. It's not a comprehensive model, but we consulted tribal people in Gadchiroli as to what sort of healthcare they would need. And in place of huge buildings of hospitals, they asked for hospital of huts. So we began 30 years ago with a tribal friendly hospital. A design of tribal hospital in tribal area can be different. We should be welcoming to tribal rather than intimidating. We asked them, Tribal Health Assembly, we used to organize every year Tribal Health Assembly and ask them what you think should be the health priority on which search should work for you. And they actually voted on various health priorities that they initially identified in discussion. And look, these are the 4 health priorities that tribal people identified. Malaria, white discharge among women, alcohol and alcoholism, and child deaths. So when you ask them, they have sufficient experience and they know their health priorities. Instead of pushing national health priorities on them, actually local health priorities should be decided through tribal health councils and assemblies. Now for child mortality, the home-based newborn care pattern that we developed by training the village women in the village itself, the traditional attendant, birth attendant, a community health worker, on which Asha was later on partly designed and trained for, and mother and grandmother. Now these 4 women together, through their training and their empowerment, the infant mortality rate in 39 villages in Gadchiroli from 121 came down to 30 in 2003, much ahead. India has reached 30 level of IMR now. So if we have a community-based model, now it has become part of the ASHA training, and through ASHA, this approach is now provided almost throughout India. 9 lakh ASHAs provided this home-based newborn care to 11 million neonates. So essentially, this is an empowerment model. Instead of waiting for experts and technological solutions and big hospital, local people, local solution, local empowerment, though not all, a large proportion of health problem could be addressed. I'll just take another one issue. Alcohol and alcoholism and addiction is a common problem in several tribal societies. And a movement against alcohol emerged in Gadchiroli, primarily driven by women, tribal women. What you read here is Darubandi Jhalis Paije. We want prohibition. And this movement resulted in prohibition being introduced in Gadchiroli nearly 30 years ago. In spite of that, because of the partial implementation, in 2015-16, when we did district sample survey, 41% males drank alcohol. Earlier, before prohibition, it was 60%. 80 crore rupees was spent on purchasing alcohol. 44% population, including children, consumed tobacco, and rupees 298 crore was spent on purchasing tobacco. So total money spent on alcohol and tobacco out of pocket was 370 crore rupees, which was almost twice the district development plan of government for Gadchiroli. So alcohol and tobacco became major issues. And so we started this Mukti Path, freedom from alcohol and tobacco and development. A strategy was designed: demand reduction, supply reduction. Demand reduction through mass awareness and de-addiction activity, supply reduction through community action and legal ban enforcements. Here, local tribal women are tying Rakhi to police, asking from them that illicit alcohol and tobacco in their villages have to be stopped by police. But communities organize themselves and take Swaraj empowerment in their own hand, that illicit alcohol, if police doesn't stop, we will stop ourselves. There are several villages which have declared themselves alcohol and tobacco free. Nearly 400 villages have become alcohol and tobacco free. But this didn't stop at alcohol and tobacco. Then these communities spilled their awareness into election, and they said, we do not want to elect anybody who supports tobacco and alcohol. So they are asking for all the candidates and parties that candidates must be supportive of prohibition and candidates must not distribute alcohol. De-addiction program in the village itself, a community-based de-addiction program. Look at the impact. Prevalence of alcohol consumption. It was amongst men. From nearly 41%, it came down to 29% in 3 years. 29% reduction as compared to the baseline. And money spent from 80 crore per year, it came down to 44 crore per year. These are all based on annual district sample surveys done with the same methodology. Tobacco prevalence, from 43% in 3 years, it came down to 34%. This rate of reduction is 5 times faster than tobacco reduction in the rest of the Maharashtra. And expenditure on tobacco again reduced by nearly 55 crore rupees. So these community-based empowerment interventions and district-wide program could successfully, I wouldn't say completely, you don't expect really miracles, but partially reduce tobacco and alcohol consumption prevalence, saved money, but most important, strengthen communities, strengthen women's organization, including in improving their presence in the democracy, grassroots democracy. Here, this project and the findings were presented to the then Chief Minister, who then agreed to spread this to 3 districts. So what I presented about Gadchiroli is not the last word, not the solution. Few glimpses of how through participatory and empowerment approach, some of the issues can be taken up with the tribal people, and in their collaboration, issues could be partly solved, but our search continues. There is no end to it. Thank you so much.
Yes, thanks, Abhay. I think we will now move on to the question answer. There are many questions. Actually, there's one that is talked about, the experience from countries like Canada, Australia, and, where colonialism was a factor. And the issue of, historic trauma and genocide as being one of the reasons for, the mental illness and self-harm, etc., that is faced in those communities. I think all 3 of you all have talked about the higher levels of addiction. Do you think that there are some of these deeper issues? Maybe I would take this question to Dr. Glenn. If you can put on the video also, please. Yeah.
Yes, colonialism is definitely a very significant factor. We are all aware that decolonization has now really gathered pace as a movement in the last few years. We're all aware of the apology tendered by the American Psychological Association a few months ago, apologizing to the community and to the discipline for the colonialism and for the discrimination that has been widely prevalent in the discipline of psychology. 6 months earlier, we had a similar apology from the American Psychiatric Association. And as we all know, leading universities around the world, starting with Harvard and Oxford, have actually brought in decolonization as major strategies in the last couple of years. Why is this so important? It is very important because the legacy of colonialism, even though the colonial masters have gone away in terms of economic and military and political domination, the term coloniality, which refers to the vestiges in our health, education, and culture, they still remain very strong influences. Now, the effect of colonialism on the country is seen in books like Shashi Tharoor and recently from Harvard. Her name is Wilkins, I think. But what these books actually don't say is that the cumulative effect of colonialism, which is felt even today, has victimized tribal peoples in India more than the non-tribals. Why is that? It is because of certain economic practices such as the revenue system, in which lands were taken away from the tribal people, in which they were evicted from the forest. That's one. It is the fact that conversion to Christianity happened to tribal people in a large way compared to non-tribal people. So this meant that there was a diminishment of culture. Belief systems were declared as savage and superstitious and heathen. So some of the traditions which sustained people, in terms of their psychological being, were also lost. So when we talk about colonialism, just like how it affected populations in North America because of settler colonialism have also affected indigenous peoples all over the world, and definitely so very much in India.
I was just wondering if you had any thoughts about, or if you know of any, measures that can be taken to address this decolonization. Yes, I mean, in India, it's not, it's talked about, but in very small circles. But in terms of how does it actually impact on the ground in terms of the health system? There's another question that says that there are health professionals who are working in these areas who actually impose their own thinking and their theoretical knowledge based on their training onto the local communities. And they don't seem to be willing to learn or to listen with respect or to learn from the communities. They don't seem to have that ability. Any thoughts on this? Maybe I'll stick with Dr. Glenn for this and then maybe go to Melari too.
I think what's a key important strategy here is that tribal cultures must be preserved. Tribal cultures must be encouraged. Tribal cultures must be revived, because it's not only the economic well-being, okay, that has suffered because of damage to culture. It is also psychological well-being, mental health, and with that, the whole picture of health. Thelma, this is something that is very fundamental. Okay? I mean, we can say that from the time that India started, there have been so many schemes, policies, but the litany of problems, okay, is the same. We end up repeating ourselves with all of these strategies. Everything is still a handout. Okay? Everything is still prescribed. There has been no effort to engage with tribal communities with the view of allowing them to express their culture, because cultural comfort is key to well-being. So I think all health policies, all education policies, okay, must have this strong component. School textbooks in India talk about so many of the ethnic communities in India, but there's hardly any line or two about tribals, who are 100 million of this population. So this neglect of tribal culture is really the root problem of the issues that we face today adversely in health and education.
Melari, would you like to add to this?
Yes, I agree, totally agree with Dr. Glenn. And in fact, I would add that even if there's a mention about tribals in the textbooks, I think it's very derogatory in the way they portray tribals, right? So therefore, it's, we, as I said, our mindset is very important. So therefore, if a health professional, studies, medicine, or any other, allied health sciences, they would go down to the community with that perspective that they have, they don't know anything, so that's the whole mindset, that people don't know anything, and we're there to give whatever is there, and you listen and you take it, right? So therefore, this mindset change, I think, is very important. I think earlier, Dr. Glenn has mentioned that hardly any curriculum is there on tribal health in terms of, people studying medicine and other allied health sciences, or even public health for that matter. So I think it all starts from there. You cannot change a person's perspective overnight, but that change can come when they slowly get oriented to how the approach should be towards healthcare and towards basically healthcare, and also encompassing even traditional knowledge systems, I suppose. Yeah.
There is another question about any possible reasons that you all may be able to cite for school dropouts, across ages, and especially in girls. What do you think are the reasons for school dropouts? It was mentioned, I think, by you, Melari.
Yes. Okay. As far as my experience in terms of working with communities here, in terms of school dropouts, they mainly drop out because of poverty, because they have to look after, the younger siblings. That's one. So therefore, it's usually the eldest sister who would look after. The second is they drop out because the middle school is not available in their villages. So therefore, they have to go out of their villages to go for the upper primary education or even secondary education. So therefore, they drop out. So these are the two main reasons that they drop out. And of course, if there's, they land up in a pregnancy or something, that's the other, reason that they drop out of school.
There's an interesting question here about involving cultural arts in mental health as being crucial. As an expressive, arts therapist has mentioned. I wonder if you in the university or in Gadchiroli have actually tried this or used this as a method of, the traditional art, using the traditional art forms.
If I may say a word on that, Thelma. Okay. Tribal life is very colorful. Schools are black and white. Does academics reflect tribal life? No, not at all. When we have a seminar, you'll find that it's a very dry and a very formal event. Okay? A week ago, we had a seminar on geodiversity in our university, but there was a colorful ceremony with music and dance to begin that. The whole hall is decorated with cultural motifs. Okay? There's pictures on the walls, like a small exhibition. In other words, we create a tribal festival even for an academic event. Okay? You may be familiar with the book that's come out recently, written by Sean Wilson. He's an Aboriginal academician from Australia. And the title of the book is Research is Ceremony. In other words, everything that we do by way of education or health or research in a tribal community must reflect the color of tribal culture. Then only it has meaning. When we talk about school dropouts, Meghalaya has the highest dropout from schools in the country. By class 12, 85% of students have dropped out. It is because there is cultural alienation. Tribal children don't find usefulness or connectedness with the education that they are receiving. So why stay in school? It really does not translate into anything beneficial. I've talked to people from Gundalur and from Bisamkatak. You hear these same things from other tribal projects as to why there is dropout, as to why conventional education is not working. We need a different kind of education. We need an education from people like Paulo Freire, which truly reflects tribal culture.
There is a question about, do traditional healing systems and medical systems differ from community to community? And Abhay, I'm wondering during the years when you all were in the National Expert Committee and maybe you all visited some of these areas, or maybe any of you can answer this. I mean, there is, I would assume, a diversity, but I'd just like to have your views on this.
Yeah, but what is the question? There is a diversity, but the question is?
In terms, and how would you bring it into play when we're going forward towards UHC? How can we integrate it with our more formal efforts?
The moment we accept that the most fundamental right as well as the attribute of tribal community is autonomy and sovereignty, it would apply even to culture, and it will also apply to their local healthcare system. So the traditional local healthcare system of tribal people, you don't have to standardize them and make them uniform all over the India. They are going to vary locally. That is their richness. That is their beauty. So I don't think any attempt should be done to sort of standardize them, make them similar and then apply nationally. If we really design healthcare system with local participation, then probably involvement of the local traditional healers as well as culture would be stronger than it is today. As both of the co-panelists mentioned earlier, actually colonialism not only was faced by the indigenous people in the West, but tribal people here faced through a series of colonizers. Waves and waves of outsiders. And as Mahatma Gandhi says in Hind Swaraj, that even if British people go, if we continue with the British mindset, people of India will be still colonized. So actually we are in a way, all of us, including the tribal people more so, are in a sub-colonization kind of situation. Now, tribal medical healthcare system has not received any serious attention. It has not received due respect. Actually, even the anthropological studies and pharmacological studies have not been done. So on one side, we need to give respect and involve tribal healers and tribal cultures in designing local healthcare system because people want it. But at the same time, we on the scientific basis also, we need to evaluate, investigate, find out which are effective, which are not effective. And those remedies which are effective naturally need to be encouraged more.
Thelma, I should mention that sorry.
No, there is one very interesting question which I am keeping an eye on the time also, and I'll come back to you, Christo, Glenn, on the same thing, on what you were going to say. But just to throw in this question, that why are tribals still considered as voiceless victims? We have had our own people, tribal people running governments at state level, etc. So it cannot be that tribals are voiceless and powerless. There are other problems that need to be deliberated.
I think tribals are by and large voiceless people. One is the innate personality of tribal communities where they are not assertive, they're not aggressive. They would like to be kept on the geographical fringes and left alone to their cultural traditions. Even the tribal health report, which was discussed in this particular webinar, includes only 2 tribals. Why were they not in the majority? Why is it that some things are being set up like a tribal health council when we have not been consulted? Maybe we have traditional organizations, traditional governance systems that could be used as tribal health councils. Why do we need another new body? So there are new organizations, new cadres that are always being thrust on tribal communities when there has not been given enough consideration as to what existing systems or persons in the community may be brought in. In this respect, I should tell you that in Meghalaya, the government has passed the conservation and promotion of Khasi traditional medicine, which has 4 components. One is registration and licensure of traditional healers. The second one is setting up a Khasi Traditional Medicine Institute. The third one is setting aside medicinal plant wildlife sanctuaries. And the fourth one is investing the intellectual property rights with the Khasi community. Now I'll bring this back to the voice. When this legislation took place, we had a visit from a central government body in which they said, we will come and we will do the certification of your healers. But they were bringing an outside system by which outsiders would assess our own healers. And they were creating a hierarchical system in which tribal healers were at the bottom of the ladder. So suddenly there was a caste system even of traditional medicine in which tribal healers were placed at the bottom. This again is another example of how we feel that we don't have a voice.
So there is a question about why should not local healers, traditional healers, be part of the public health system? You know, why have a separate cadre? You know, it links to some of the things that are being talked about. And I may just add one last question, which is slightly different, but it'd be useful to have your thoughts about the role of drones in terms of supplying, you know, equipment or supplying whatever. That's a different topic, but since one of the work streams of the commission is on technology, it'd be good to hear your views. So for the local healer as being as a part of the public health system, Abhay, what would you say?
It's an interesting idea, but consider it at the implementation level. And so on one side, the respect to the tribal healthcare system and its involvement, participation in the health is necessary. But the primary healthcare system, as we all know, it's not ideal. and it runs in a particular hierarchical manner, and it is entirely based on modern medicine and concepts of modern medicine. Now, how will they two be harmonized and united at the bottom level? Imagine a primary health center, or imagine a health sub-center. If there is one nurse, one community health officer, and one tribal healer, how will they work together? So it's an enormous challenge, and I don't think we should very lightly recommend it romantically. If we really are serious about it, it needs not only operational pilots, developing various mechanisms and solutions, but at the same time, an ethical issue would come up that do we know that these are effective? Are these methods safe? So simultaneously, parallelly, intensive research has to start to assess this efficacy and safety of some of those measures. Otherwise, a public healthcare institution can be both legally challenged as to how are you allowing these healers and these practices whose safety has not been proven in medical science. So I think government will be caught in a very difficult situation to really implement this suggestion.
I think we are coming to the end of time, so I think we should probably conclude. A one-line word about drones, if anybody wants to make.
Yeah.
Well, it's a good idea, especially in the remote and hilly and forested areas, supply system through drone. But I would really go for more knowledge, spreading knowledge. And so if at all there could be drones of knowledge, that will be more useful. But for supplies in remote areas, drones could be a useful weapon.
So with that, I think we've come to the close of a very, very interesting conversation and seminar. I hope participants have valued it. I think from what I'm hearing, even people from Sweden are saying that they could. It's been very useful, and it would be applicable even to the tribal communities there, the Sama group, if I've got it right. I feel that we will need to take this forward, whether it's through networking, through individual contact, through organizational contact, because left to itself, we will continue in the way it has been. So I think some countervailing power, some countervailing assertion is probably required in the larger interests of the tribal communities in India. And they do have abilities and strengths, as is very obviously seen by the presence of our two panelists, Dr. Melari and Dr. Glenn Christo, with immense knowledge and immense articulation. And I'm sure there are others also. So maybe having those sort of informal networks, we may not need to rely so much on the formal system. But at the same time, one can't ignore that, because the health data that was shown even by Dr. Melari requires definitely requires attention. So a process of engagement between the public health system and, traditional knowledge systems, as well as local healers, is something. It may not be that easy. There's no easy road ahead to any of these, but I think engagement between all these stakeholders is essential. How the Lancet Commission, which depends so much on this research-based work, what are the different types of research that are used by which this can be articulated and brought into the discourse, is something that I think as a commission we will need to discuss further. With that, I know we've crossed time, so thank you very much to our three panelists. It's been wonderful having you. Thank you so much for taking time off and sharing your deep thoughts. Very, very warm from the heart. Thanks, and we'll keep in touch. So bye-bye.